Okay, so today I'm going to talk to you about exercise testing in patients with cardiac rhythm devices. I don't have any disclosures. I thought today I would start out with a basic review of implanted cardiac rhythm devices. I think for some people in the room this will be pretty straightforward, and for some people this may be brand new, and for most of you it will be somewhere in between. I wanted to talk about special considerations for exercise testing in patients who have pacemakers and ICDs and what we do in our lab. And then I thought it would be best to illustrate this with some cases, because this is not an area where there are a lot of papers or research. This really just comes from clinical experience. Okay, so you'll see pacemakers, ICDs, and then sometimes devices like implantable loop recorders in the lab. Pacemakers in pediatric patients can be epicardial, meaning the leads are on the surface of the heart. They can be transvenous, meaning the leads are inside the heart. And in the adult population, we're starting to see some leadless devices, but I'm not going to talk about those today. We have yet to put any leadless devices in our patients. ICDs, most of the time are transvenous, but in the pediatric population, it's not that unusual to see epicardial ICDs. And then in our institution, we're starting to use more subcutaneous ICDs, so we'll talk about the exercise implication of those devices as well. And then implantable loop recorders, I'm not going to spend too much time talking about that today. I think it's important that you know if your patient has one and that you get the most recent interrogation to know if they've had any events before you start testing them. But other than that, there's not too much to do in the lab if someone has an ILR. So pacemakers are used to provide AV synchrony or chronotropic support. They can pace. They can sense what's happening in the heart from an electrical standpoint. They respond to increased metabolic demand and can change heart rate if you put rate-responsive programming on them. And they can provide a lot of diagnostic information that's stored by the pacemaker. They can tell you what abnormal rhythms a patient's had recently. They can actually give you some information in the transvenous devices about progression of heart failure using Optival and other techniques. And some of them can also provide overdrive pacing to get patients out of atrial or ventricular arrhythmias if they're programmed to do that. But pacemakers cannot deliver any shocks. Pacemakers are made up of an implantable pulse generator, which is usually in the left subclavian area, but can be in the right in some patients depending on their underlying anatomy. And sometimes, if it's an epicardial device, is located in the abdomen. And then every once in a while, when we put a device in a very small baby, there is no space for it, or if they have other congenital anomalies, it won't fit in the abdomen. So we've come up with some pretty creative places to put the device. So if you ever need to test someone who has one of those devices, you want to ask them where their generator is located, because it may not be in one of the traditional locations. And then patients will have either a single lead in the atrium or ventricle. They can have a lead in the atrium and the ventricle, or they can have a multi-site, or they can have leads in both ventricles trying to do resynchronization pacing. ICDs detect and treat arrhythmias. They have the ability to pace as well, unless you have a subcutaneous ICD, which the current models do not pace. And they can be used in patients with a variety of congenital and acquired heart diseases. We're starting to use a lot more sub-Q ICDs, because in ICDs there can be a lot of problems with the leads themselves. And so ICDs don't put any leads inside the heart. And that is fantastic if you're looking for defibrillation therapy only. But a lot of our patients require medications that would make you want to, medications that can decrease their heart rate, and the pacing backup can be very helpful. And the sub-Q ICDs don't have that. And then ILRs I talked about briefly. They're there to monitor for abnormal heart rhythms. We use them in patients who have symptoms and we're not able to detect what their rhythm is at the time of their symptoms through the less invasive measures. And then we also use them in patients who have ion channelopathies with unclear risks, or people we think are at risk for arrhythmias, but we haven't quite gotten to the point of wanting to put an ICD in them. They don't have any leads, they don't deliver any therapy, and all they do is give us information about rhythm. And these are just a few different x-rays. This one here, I don't know if you guys can see my pointer, is an epicardial dual chamber pacemaker. The other top right up there is a transvenous ICD. Down here, this is what a loop recorder looks like by x-ray, and then the bottom dual panel is what it looks like if someone has a subcutaneous ICD. So what do all these pacing modes mean? I get this question a lot where people are like, I don't know, it's like DDD or something, and I don't know what that means. So I thought I'd go through that a little bit. And this list here is not an extensive list, but these are the most common modes that you'll see. So the different letters refer to different things. The first, if you go back here, so the first like A or V, that letter tells you about the chamber that's paced. If there's an O or a 0 in that position, then that means that there is no chamber paced. If there's an A, that means you can pace the atrium. A V, pace the ventricle. And a D means that the device is able to pace both, or dual, the atrium and the ventricle. The next one is about what's sensed. So if there's a 0 or an O there, that means that you're not going to sense anything. And we'll put patients into a mode where they don't sense, sometimes if they're going to the operating room and are going to have BOVI, because that can trick the device into thinking there's electrical activity in the heart that isn't actually happening. And so patients will not pace when they need to pace. So if you put them in a mode where it ignores electrical activity, you can allow your patient to continue to pace through an operation. So the next, and then obviously A is atrium, V is ventricle, and dual is both. The third one is what's the response to sensing? So you don't want your patient to pace a chamber if they had an intrinsic event in the chamber. So if there's an I in that position, that means in response to a sensed event, the device will be inhibited. So if you have somebody who's paced VVI, so they can pace the ventricle and sense the ventricle and inhibit in response to a sensed event, then you will not have an intrinsic ventricular response followed by a paced ventricular response. And that's good because you could put your patient into VT with that, and we don't like that. And then the last one, which isn't always used, is rate modulation in the fourth position. Actually, there's a fifth position also that has to do with whether you have overdrive pacing, which we occasionally use. And again, we don't tend to put the O or the 0 there if rate modulation is not on, but we will put the R there if rate modulation is there. And then that means your patient's heart rate can change based on their metabolic needs, even if their own heart isn't able to do that. So just a couple of quick reviews. This is what typical AAI looks like. Pacing the atrium, sensing the atrium, although you don't see any sensing here, these 3 beats are all paced. And then if there were a sensed P wave, then the device should not pace if it's working correctly. VVI, same thing. This cartoon is supposed to depict somebody who's in atrial fibrillation, and so the patient has mode switched into a mode where they pace their ventricle but do not track the atrium, because we don't want them tracking the atrium at that rate. So this patient has switched into a backup VVI mode while they're in an atrial arrhythmia. And then this is one way that dual chamber pacing can look. In this patient, you see pacing of the atrium and pacing of the ventricle. But you can also have atrial pacing with ventricular sensing, meaning you won't see pacing of the ventricle if the patient has intact conduction. And sometimes patients who have dual chamber devices will have periods when they have intact conduction and periods when they don't. So then you can see them switch over to atrial sense ventricular paced, meaning, which is the next one here, meaning that, I can't see that, there we go, meaning that it's sensing the atrium and pacing the ventricle. And then every once in a while we'll have people, especially patients who have surgical heart block, will have periods of time where their conduction transiently returns. And so you may see someone who's both sensing the atrium and the ventricle. And then if your device works appropriately, you don't try to pace that patient because you're sensing their intrinsic activity. And then there's another mode that confuses a lot of people. It's called managed ventricular pacing. And the idea behind this mode is to protect the ventricle against chronic pacing if it doesn't need it. So especially in our patients who have congenital complete heart block, what we see over time is they can develop a cardiomyopathy, and some of that cardiomyopathy is thought to be secondary to chronic ventricular pacing. So if you have a patient who has periods, who has prolonged first-degree AV block, it's hard to program the device in a DDD mode to not pace the ventricle, even though their conduction may be intact. Or if they have periods of second-degree AV block, you don't want them pacing the ventricle all the time if you don't have to. So this device actually this programming actually waits for 2 missed atrial signals in a row before reverting to pace the ventricle. And there's different algorithms that we program into it or that are already programmed into it to determine when it checks again to see if intact conduction is back. The reason you need to know about this is you could imagine in the lab this could look pretty weird. And so you are seeing there's pacing, and then there's a P wave, and there's no QRS, and you don't know what's happening, and then it paces. And so if the patient's in this mode, you may see something like this, especially before they start exercising. So what is sensing? Sensing is the ability of the pacemaker to determine if the heart has made its own beat. And the pacemakers, like I said, are programmed to respond with a pacing impulse only if the heart fails to produce its own beat. Accurate sensing ensures that undersensing won't occur, meaning that the pacemaker will not miss a P or an R wave that should have been sensed. It ensures that oversensing will not occur, meaning the pacemaker doesn't interpret noise or other electrical activity as a local internal cardiac event. And it provides for proper timing on the pacing pulse. So an appropriately sensed event resets the timing sequence of the pacemaker and allows all the different intervals that we program in there to work correctly. This is just a schematic of what undersensing looks like, and this is pretty dramatic. It's not actually usually that easy to see. So this patient's VVI, so you see their V pacing. Here, they have a very normal sinus beat, and obviously this device is in big trouble because it doesn't see this at all, and so it tries to pace the ventricle again, and it paces right at the beginning of that T wave, so that makes you a little nervous. Then there's another intrinsic sinus beat, which again is not sensed appropriately, and the device again paces the V. So if you see a patient who's got a strip that looks like this, that's a problem because you could be at risk of having a patient go into an abnormal rhythm in the lab just because of their pacemaker and it's undersensing. Oversensing occurs in times like in the OR if someone has a bovie, or if the lead is starting to fracture, there's noise on the lead. You see down here, it says down here, this is a tracing from a printout from the device. The device thinks there's a whole bunch of ventricular activity happening, but when you look at the rhythm strip, there's no ventricular activity happening. Why this matters is if the device thinks that there's underlying electrical activity, it doesn't pace. So you can have patients with very long pauses because the device thinks there's electrical activity that is not occurring. So switching to ICDs, ICDs can provide a variety of different therapies. They can provide anti-tachycardia pacing. So anti-tachycardia pacing occurs when the device detects an abnormal rhythm. We've programmed in for the device to be able to do this, so you have to tell the device you want this to happen. And it will deliver a burst of rapid electricity to try to interrupt the reentrant circuit of the arrhythmia. So it only works if their arrhythmia is reentrant. It's great for atrial arrhythmias. Our adult Fontan patients, a lot of times we will have these therapies programmed into their devices because if they have a lot of atrial arrhythmias, they don't want to have to come in every single time. And if we can figure out what cycle lengths are good to get them out of it and they're able to get out at home, that's better for them as long as we're monitoring them and know that this is happening. It can also be delivered for ventricular arrhythmias, and many of the newer devices will deliver ventricular pacing during charging if the ICD has determined that a shock is needed, because in some very rapid ventricular arrhythmias, sometimes overdrive pacing can terminate the arrhythmia. Overdrive pacing doesn't hurt, and it doesn't deliver a big electrical shock to the heart, so you can sometimes terminate the rhythm and abort the shock that the device is trying to give. And then cardioversion happens when the patient's in VF and, is in VT or rapid VT, and it's synchronized to be delivered on the R wave. And defibrillation obviously happens when they're in VF and there isn't an identified location to deliver the shock. So what do you need to do when a patient's in the lab and they have a pacemaker? What do you need to know about them when they come into your lab? Obviously, you need to know why they have a pacemaker. So it's important to figure out, was this put in because they had some sort of surgery that damaged their sinus node? Do they have complete AV block? Do they use their pacemaker all the time? Do they use it rarely? And how is it programmed? You need to understand the patient's programming to know what you're going to see in the lab. It's important to know if it's transvenous or epicardial. Mostly that's important for the person managing the device, but we will often throw the programming. We keep the devices open during testing, meaning we interrogate the device before we start testing, and then we leave that interrogation open. So we can throw the programmer head right on the patient during the test if we want to understand what's happening with their rhythm, or sometimes I'll reprogram the device while the patient's exercising in order to try to improve what I'm seeing in the lab. So if you don't know where the patient's device is and they're running on the treadmill and you're like, is it up here, is it down there? So it's important to know where it is before you start, and then you don't have to interfere with the patient's exercise quite as much when you're trying to make changes during the test. It's also important to know if there's any concerns with the device. So are there problems with the lead? Does somebody think that the lead is starting to fracture? Are there problems with the impedances? Have there been a lot of arrhythmias detected by the device? Because you want to know that before you start exercising your patient. We have a lot of patients come in for a rate responsiveness evaluation. So they've got rate responsiveness program, but they don't like the way it feels, especially patients who didn't have rate responsiveness for a long time and then get it programmed on. It feels funny to them. They don't like the way their heart feels. And so you want to know that that's the type of evaluation you're going to be doing in the lab. And then not everybody leaves the devices open during testing. I leave all of my cardiac rhythm devices open during testing. It gives me a lot of flexibility to both understand what's happening during the test and to make programming changes real time to see if it makes a difference. So for the ICD, pretty much the same list of things you need to be aware of, but the other thing I think is really important to understand about patients with ICDs is, why does your patient have an ICD? Is it for primary prevention, meaning they have a risk of a ventricular arrhythmia but they've never had one before? Or is it secondary prevention? They've had a VF arrest, they've had a cardiac arrest, we've determined that there's a rhythm problem, and now they have this device for that. If you have that patient in the lab, you need to understand that that's a patient who could do that again in the lab, and you need to be on the lookout for signs that that could be happening. And then, is it transvenous, epicardial, subcutaneous? The important thing about the subcutaneous ones, which I'll get to later, is that it uses a series of vectors to determine, because there are not leads in the heart, whether the rhythm is normal or abnormal. And sometimes with exercise, those vectors can change anyway. So there are case reports in the literature, mostly of adults receiving inappropriate shocks during exercise and during exercise testing when they have sub-Q ICDs. So that is something that you really want to understand when you have your sub-Q ICD patient in the lab. Again, have there been any events recorded by the device? Do they have a lot of sort of what we'll call junky ventricular stuff when we interrogate their device? Nothing long, nothing that's needed a shock, but some stuff that you're going, I don't like that so much. And on those patients, some of these patients, you'll see some ventricular ectopy and you're like, all right, keep going. Other patients, when they've got a lot of that stuff and they have a device for secondary prevention, you might terminate that test earlier than you would for somebody else. And then, did they take their medicines, their antiarrhythmics that day? Because they're always compliant except the day of the test. And so for some patients who come in and they have a really strong arrhythmia history, if they have not taken their antiarrhythmics that day, I send them out of the room, because I don't need them going down on the treadmill for me. It makes for a bad day for all of us. So that's an important question. And I always ask them what time, because some of them take it in the parking garage before they come in for the test. And so that's usually, we'll bump them to the end of the day, let their medicines kick in a little bit before they get on the treadmill or the bike. And then, like I said, I always leave these devices open. I think it's really helpful. So switching gears to a few cases. This is a 9-year-old patient who comes into the lab for her first stress test. She has congenital complete heart block, and you do your due diligence, you review her chart, and you see that she had an epicardial dual chamber pacemaker implanted on day of life 1, and then she was lost to follow-up, and she showed up to clinic at age 3.5 years with a ventricular lead fracture. And she's pale and lethargic, and her heart rate was in the 40s, and her echo looked terrible. And she went to the OR that day to get new leads and a new generator implanted. And at that point, she was switched from unipolar leads to bipolar, which is better based on her age. So now she shows up for the test, and one of the first things you want to know is her pacemaker working, right? Because this is somebody who's shown up for care at times and has not had a working device. So you interrogate her device, or you bring in whoever interrogates devices in your institution, it looks like her device is working. So that's great. So how's she programmed? She's DDD, meaning she can pace in both chambers, sense in both chambers, inhibit in response to a sensed event, trigger when she needs to if there isn't a sensed event. Her underlying rhythm is complete heart block with a rate of 47. So for a 9-year-old, she would probably still be standing with that rate, but she may not look that good. So if there's a problem with her device, you should know that. And you see that she's A-sensed, V-paced 91% of the time, A-paced, V-paced 9% of the time. So she is 100% V-paced, and she is dependent on her device. Just for some history, this is her EKG at birth. So you see that she's got a lot more P waves than QRSs, and she's got this nice narrow QRS escape. And had she been metabolically in a better position right after birth, she might not have had to go to the OR, but she was pretty acidotic and a pretty sick baby. This was her EKG after she got her pacemaker placed as a newborn. And you see these great big tall pacer spikes here. She's mostly A-sense V-paced. When you see these huge pacer spikes like this, that tells you that they have unipolar pacing, which means that one pole is at the tip of the lead, the other pole is at your can. And for pacing, that doesn't matter quite as much, but for defibrillators, that can matter quite a bit. This is when she showed up at 3.5 years of age. So not such a pretty looking EKG, nor was she a pretty looking patient. And then this is her baseline EKG at her stress test. So this looks good. She's A-sense V-paced. Now you see that she's got these tiny little pacing spikes here. That's what bipolar pacing looks like. So there's a big difference in the EKG when someone has unipolar versus bipolar pacing. This is 5 minutes of exercise. Looks good. She's still A-sense V-paced. This is peak exercise. She's still A-sense V-paced. So she had a nice normal test, and she has normal pacemaker function. No changes were needed to her device. So now you have a 12-year-old who presents for their stress test. This is a patient who initially presented at 5 weeks of age in cardiogenic shock, metabolic acidosis, profound cyanosis, and ventricular failure. This was a patient who was not diagnosed at birth and rather received their diagnosis of a single ventricle at 5 weeks of age. This resulted in her being quite ill and having a really rocky early course. She went through the pretty typical single ventricle course with a Norwood and a DKS and a bidirectional Glenn. She had a lot of atrial arrhythmias during that time and some ventricular stuff as well. And when she went for her Fontan, she had a biatrial maze procedure. As a result of the biatrial maze procedure, her sinus node was damaged, so she also had an epicardial dual chamber pacemaker implanted at the time of the Fontan. Her current programming is DDDR. She has the rate responsiveness on because her sinus node isn't so great, we think, and 70 to 150. And when you look at her device, she's had 4 atrial arrhythmias recorded since she was last interrogated, and has had 16 ventricular brief high rate episodes. So things to keep in mind as you put this 12-year-old on the treadmill. Her underlying rhythm is a junctional escape rhythm at 47, so she also would not feel very good in that rhythm. And she's A-paced V-sensed 95% of the time. So she really is using her atrial pacemaker, and you would expect that if you see someone with rate responsiveness on there. So just so you get an idea of what her EKG looked like, this is her EKG at presentation at 5 weeks of age. And the reason I'm showing you this is you'll see that her PR interval is extremely short. We did an EP study on her. She does not have WPW. This is the pseudo pre-excitation that we sometimes see in single ventricle patients. But it's helpful to know what her EKG looked like now, when she was a baby, so you understand what her pacing looks like now. This is just her chest x-ray, so she has her generators in her abdomen and then leads on the ventricle and atrium here, and she has a coil. So this EKG looks like it's showing V-pacing. but it's actually A pacing with intact conduction to the ventricle. So if you see someone come in with this and you're thinking, what chamber is this device pacing? If your device is open, you can just look over at it, throw the programming head on, and you'll see that it says A paced, V sensed, and then you know. But if not, you could also go back to her EKG when she was a newborn and see that she has intrinsically a really short PR interval. So this is 3 minutes of exercise. Looks pretty good. She's still A-paced. It looks like her pacemaker rate is increasing as she increases her exercise. So it looks like her rate responsiveness so far is programmed appropriately. She is giving us the thumbs up as she exercises that she feels okay. And now this is 8 minutes in, and her heart rate's only 134, but to her this feels normal. She has not in the past wanted more rate responsiveness programmed in her device. And then this is 8 minutes and 46 seconds. And so this is really interesting. You're thinking, what's happening here? So, looking at the EKG, I suspected that she was in sinus and that her own sinus or atrial rhythm had kicked in, so her device had appropriately inhibited because that's what you want it to do. But if you weren't sure, you could throw a programmer head on her and look at what's happening, because the other possibility is that she's in some sort of atrial arrhythmia, or that this is a junctional tachycardia, but that wouldn't really explain why her atrial pacing was inhibited unless she has intact VA conduction. So again, this is another illustration of why it's important to have your programmer in the room so that you can understand what's happening with the patient. This was her own rhythm. This was sinus. Her sinus rhythm, although she paces most of the time, when she really stresses her heart, she is able to increase her own intrinsic rate, which is also great because her device actually goes up to a rate of 150. And so we don't have a lot of room to program her with an atrial rate faster than that, just based on the age of her device. So she was there for a rate responsiveness test to see if she was also a Fontan, so she was there for a lot of reasons, but she was there primarily to see if her rate adaptive pacing was programmed appropriately, and for her, it appears that it was, because her own rhythm kicked in, and early on it seemed like her rate increased in a manner that was comfortable to her. So these tracings demonstrate normal function of her rate responsiveness. And we use exercise testing a lot to assess and adjust the rate responsiveness programming for our patients. And what I'll usually do for patients after I adjust it is I'll throw them back on the treadmill and just do a quick sort of non-formal stress test on them to make sure they feel okay with the changes that I made. Because what may look nice to me on a graph and based on what I'm seeing on their EKG may feel really horrible to them. And so sometimes the changes I want to make, we have to make over a period of time to get them used to that feeling. Okay, so this is another case. This is an adult with a Fontan. So a 30-year-old patient who had a double inlet left ventricle and has the Fontan completion and has a lateral tunnel Fontan, and again went through sort of the typical course to get there. This patient has an epicardial single chamber pacemaker implanted for sinus node dysfunction. So a lead in the atrium, no lead in the ventricle, and is programmed AAIR 80 to 180. This patient has a history of atrial arrhythmias and junctional arrhythmias. When you interrogate the device, there's no recent arrhythmias recorded by the device, and when you review the patient's last couple of Holters, there aren't slower arrhythmias either. And sometimes people say, well, why do you get a Holter on someone who's got a device and can record all that information? Well, the devices only record arrhythmias at rates that we tell them to record at. And so especially Fontan patients can sometimes have a lot of slower atrial arrhythmias, and you can't program the device to pick up those arrhythmias because that would be lower than their upper pacing rate, and so the device isn't able to do that. So Holters are still useful in these patients or longer term monitoring to make sure they aren't having arrhythmias. And so this patient is showing up for their stress test just for part of their routine care. This is their baseline EKG, so they're A-paced with intact conduction to the ventricle. And it's stage 2, this looks familiar. So this is a patient who no longer needed their atrial pacing at this rate. Again, it's hard to tell. And with this patient's history, you might be thinking, I think I see P waves there, but could this be a junctional arrhythmia? So again, throwing that programmer hat on the patient, you're going to get a better sense of, is this an abnormal rhythm that I need to be worried about, or is this just a normal response and the patient's sinus node is working? And in this case, the patient's sinus node was working fine. So then at 7 minutes, we get this mess. And this is really hard to tell what's happening, and I love when I see this in the lab. So again, big surprise in these situations. So I'm in the room for our patients in our lab with devices, so I do a lot of figuring out what's going on with the device. So throw the programming hat on, and this was a hot mess. So there were P waves falling into blanking periods, P waves falling into refractory periods. So these are periods that are programmed into the device for a variety of reasons, for timing, for safety, to make sure that this patient has an atrial device, but to make sure patients with dual chamber devices don't get pacemaker-mediated tachycardias. And so we program all these different intervals in, and looking at this patient's programming, this patient was in a faster atrial rate, which resulted in a lot of the P waves being undersensed because they were falling into blanking and refractory periods. So this looks really ugly. We're at 7 minutes of exercise. I put the programmer hat on, make some programming changes, and just briefly, the reason to do that is inappropriate atrial pacing when you have intrinsic P waves can put your patient into an abnormal rhythm. So I don't want this patient to keep exercising with all this inappropriate pacing. I want to get rid of it. I don't want to put them into a worse rhythm when they're on the treadmill. So I reprogrammed the pacemaker while the patient was running and changed a bunch of those intervals, and then we were able to complete the test, and the sensing was appropriate throughout the rest of the test. So that's an example of how your sensing can be adjusted, and this wasn't sensing meaning that the P wave was too small or that there was far field sensing, although there was some far field sensing on that patient as well, but really that your interval programming was not appropriate for what the patient needed. And if this patient went out and exercised on their own, it's highly likely they would come back to clinic and say to you, oh my God, I feel horrible when I exercise. My heart rate's really irregular, I can't tell what's happening, and I can't do it, I can't exercise. And we want these patients to exercise, so we want to try to fix this so this doesn't happen. All right, so a little bit younger patient, a 9-year-old who has complex congenital heart disease, dextrocardia, congenitally corrected transposition, ASD, VSD, and as tends to go along with CCTGA, has heart block. So this patient had an epicardial dual chamber pacemaker placed. This patient, this test is from 2006, and this patient's pacemaker was placed many years before that. So the devices that we had available were a little bit different then, and so the peak heart rate that this device can get to for this patient is 150. So for a 9-year-old, you can imagine someone with complete heart block and a peak heart rate of 150, that might not be a high enough peak heart rate for them to really be able to tolerate exercise. So this patient came in complaining of lightheadedness with exercise, and they were referred for testing to see what was happening. So beginning the test, A-sense V pace, looks pretty good. 4 minutes in at stage 2, we have a heart rate of about 150. The patient's like, yep, I feel great. Everything's good, thumbs up. Now they want to stop. And now they really want to stop. And then I finally let them stop. So what's happening on that patient is they're really getting to that upper rate behavior. So here you see that the atrial rate is above 150. So the device can't track that. It's not able to track that. And so it doesn't track it, and then it says, oh wait, there's a P wave, I got pace, or a P wave falls into a blanking period or refractory period, and here you actually see AV sequential pacing right after an intrinsic P wave, so also something you don't want. And then here the device can't figure out what's going on at all. So this is upper rate behavior. Some people will call it pacemaker Wenckebach. It's determined by a bunch of the intervals that we program in, the PVARP or post-ventricular atrial refractory period, which is something we program in to try to eliminate the possibility of patients getting pacemaker-mediated tachycardia, the different AV delays sensed and paced that we program in. And so this patient's device worked appropriately up to a rate of 150 and then couldn't give give him what he needed anymore. Unfortunately, with this patient, there wasn't much we could do because of the type of device that they had. But if you have a patient whose upper rate limit is higher, you can adjust the PVARP, your AV delay, those kind of things on the device in order to give them a higher heart rate. And so I will often make those changes and then put them back on the treadmill and see what we can do. And so even in recovery, the device just wasn't sensing or pacing appropriately. I felt kind of bad for them. I tried hard. There weren't a lot of changes we could make for that patient. Okay, so switching cases to a 28-year-old young lady who's got a double outlet right ventricle and pulmonary stenosis, status post-repair. She first presented to me 14 years ago after she had a cardiac arrest during gym class. They were in a swimming unit. She went down in the pool. Her gym teacher, who obviously we called and thanked and gave some awards to, pulled her out of the pool, did CPR, got a defibrillator, and saved her life. So the tracings from that defibrillator showed that she was in VF. I brought her to the cath lab and did a cath and an EP study on her. And hemodynamically, her heart actually looked pretty good, but she had very easily induced VT and VF. So she had a dual chamber transvenous ICD placed for secondary prevention. She went on to complete high school, college, grad school. She's awesome. She is out there living life to its fullest, giving me little heart attacks every time I see her. She's been very challenging to manage from an arrhythmia standpoint. She's had atrial arrhythmias, ventricular arrhythmias, appropriate shocks, inappropriate shocks. We've been all over the place with medication. She's been to the EP lab for ablations. It's been really a very challenging management scenario. We finally have her on a regimen that's mostly working, and she's run a half marathon. She goes hiking in the mountains. Every time she comes to me with her newest adventure, I'm like, oh, okay, let's see. So her current newest adventure is she was going to go teach in a third world country for a year. Awesome. So she came to me for a tune-up before leaving the country, and she said, and she does high-intensity interval training. She exercises at least 5 days a week, and she said, I always have some palpitations with exercise, but I feel like right now they're a little worse. This is a chest x-ray of her device. Everything looks pretty good, in good position. Look at her programming in the lab. I've got mostly monitor zones on for her atrial arrhythmias and her VT zone. Her VF zone for therapy is a rate of 200. So she's treated with Sotalol. At the time of this test, she was treated with Sotalol. And on Holters, she never got her heart rates above about 150. And so I thought it was okay to leave her VF therapy on. It's unlikely that she's going to get her heart rate to a rate of 200 from a sinus standpoint as a 28-year-old on those doses of Sotalol. So I left her therapy on. And this is how she's using her device. She hasn't had any recent VT or VF since her last interrogation, and she does her every 3-month care links, and she's interrogated in person every 6 months. And there are some atrial tach and atrial fib episodes recorded by the device, but when I look at those, they aren't real. They look like it's far field sensing that's causing the device to record that. So I think, okay, we're pretty good here. For her, this looks good. So start the test. So she is right at the beginning there, AV sequentially paced. You can see down on her rhythm strip here, atrial pacing, ventricular pacing. If she starts to anticipate exercise, her atrial rate speeds up, so now she's ascensed V-paced. And at 1 minute and 43 seconds, I start to see some PVCs. Not so happy about that. She has a history of PVCs, but not usually this early in exercise. And at 8 minutes and 51 seconds of exercise, she has this. So as people in my lab know, I've been known to let some CPVT patients continue exercising when they get their ventricular arrhythmias to see if their medicines are working, which everyone loves working with me on those tests. But in this situation, knowing her history, understanding everything she's been through, I terminated her test. So I was worried that she was going to go into VF right there on the treadmill. She's done those kind of things before. And so in that situation, rather than pushing her, and 8 minutes, 51 seconds is nothing for her. She's really fit. She's like, I can keep going. I said, no, you can't. So made some medication changes on her, and I actually brought her back for repeat testing before she left the country to make sure that, you know, I didn't get one of those phone calls while she was out of town. She did well. All right. So this is, again, changing gears a little bit. This is a really interesting case, I think. This patient came to us as a second opinion. It's a 6-year-old who had second-degree AV block as a baby and had a dual-chamber transvenous device implanted at age 1 at a different institution, which is something I don't recommend for a variety of reasons, which we can talk about some other time. But at their 6-year visit with their other electrophysiologist, they were told, your leads are fraying, so we're going to extract this system and put in a whole new system. The family wasn't so happy about that, so they came to us for a second opinion. The patient was programmed VDD, and so can only pace the ventricle, but can sense and inhibit and trigger for both chambers, 60 to 200. When we interrogated the device, the patient had stable impedances, stable sensing, and stable capture thresholds. Looking at the patient's x-ray, which I actually couldn't import into this talk because it wasn't in our system, there is a funny bend in the lead, and over time, comparing x-rays over time, it does look like the lead could be a problem, but there was no noise on the lead looked okay. So we decided to get a sense of how much this patient really needed their device before deciding whether we needed to do something about the device. So this patient came in, this is their clinic EKG, so asensed, well, yeah, asensed V-paced. They can only pace their ventricle with the way that they're programmed. And so we decided to put them in a VVI backup mode for the stress test to get a sense of, okay, this patient got a device put in for second-degree AV block. Do they even really need this device? And so you'll see here, it's a little bit challenging, whoops, to see, but you see a P wave here, and a P wave there, and a P wave here, and a P wave there. Again, if you're not sure if you see that, you can put your programming head on the patient and look at what's happening, and you would see that there are 2 A's for every V. So already at rest, before the test has even started, your patient's in second-degree heart block. But sometimes if the AV node is able to, it will rev up a little bit, and you'll get improved conduction with exercise. If you don't get improved conduction with exercise, then that's a sign that your patient probably indeed needs the device. So this is 3 minutes of exercise. You can see your patient still, it's easier to see now, in 2-to-1 block. You see P wave, P wave, P wave, P wave, so twice as many P waves as QRSs. 4 minutes of exercise, we start to see this, not so pretty, developing higher grade block with exercise. At 8 minutes and 47 seconds of exercise, this patient's AV node cannot keep up. And so the atrial rate is close to 200, and the ventricular rate is 67. So this is a 6-year-old who probably needs their pacemaker. Unfortunately, the good news is that the device is currently working, but this is somebody who now has this socked in, not very pretty looking device, because it was put in through really small vessels that we're gonna have to figure out what needs to happen and may need to be transitioned to an epicardial system with their next device. During recovery, the patient goes back into 2-to-1, and then we put the patient during recovery back into their programming, and you can see still at 3 minutes of recovery, the atrial rate's really fast. This patient really needs better cardiac output, a better ability to pace their ventricle with exercise. So that was too bad. We were hoping they wouldn't need it. So this is a patient who's an 18-year-old with dilated cardiomyopathy. She has a bi-V ICD, which was placed for primary prevention. So she was thought to have a significant risk of ventricular arrhythmias, and there was some thought that trying to do some resynchronization would improve her cardiac output. And so these are her parameters. She doesn't have any recent events, and she shows up for her stress test. I'm gonna fly through some of these because I'm just trying to show you how much this changed. But this is her baseline. She's asensed V-paced. with PVCs. And then she hyperventilates, and what you notice down here in her rhythm strip is her QRS morphology changes. And in someone with a BiV device, that starts to raise your hackles a little bit, that there may be some issue with her leads. And we had interrogated her leads ahead of time, and her thresholds looked good, her sensing looked good, her impedances were good. So I was kind of curious about why this was happening. And I did a quick re-interrogation to make sure I wasn't missing something. She has lots of PVCs during that, but goes back to that original pace morphology. And then you see through exercise, she starts switching back and forth between these two different ventricular pace morphologies. So again, that different morphology there, switching back and forth here. During recovery, you see her clearly switching back and forth. And that continued. And then her PVCs came back. She was really happy with us this day. She was pretty miserable. So then I decided after the test to look at what does her RV pacing look like? Just trying to figure out what's happening with her. So this is what her RV pacing looks like. So I decreased her outputs on her LV pacing lead down to almost nothing and got RV pacing. And then I did the same thing to look at her LV pacing. And you'll see that this morphology looks like what it looked like that she was switching into. This one looks more like what she looked like originally. So she seemed to be switching back and forth between those two morphologies, which is usually not what you want with someone who has a BiV device. And again, it continued. What was interesting about her is that she actually had what's called adaptive CRT. So those are devices that along the lead that's in the coronary sinus, there are multiple different poles, and the device, rather than doing echo work to try to figure out the best intervals to program your patient to improve their resynchronization, this device tries to resynchronize real time. So her device was resynchronizing throughout her stress test. So I thought that was really interesting. There would be nothing you'd need to do about that, but if you knew she had an adaptive CRT device rather than a traditional CRT device ahead of time, that would be very helpful. She happens to be our only adaptive CRT device, and honestly, that was my bad. I didn't see that when I first interrogated her device. So I was trying to figure out what was happening the whole time, and that was because I hadn't done my homework. So, little note on doing your homework. All right, so I'm just going to finish up with a couple of examples of what it looks like with the sub-Q ICDs. So we use treadmill testing both before the device is put in to make sure the patients are actually candidates, and then we'll do it afterwards to make sure that there aren't things that we didn't anticipate happening once they're fully healed. So this is just a picture of what it looks like. So the traditional, you have your pulse generator here, you have leads in your vessels and into the heart. And for the sub-Q, you have this generator over here, and then tunneled in the subcutaneous space is this lead that goes here and here, but it's not a lead, there's no pacing. It's just used to sense. And these are the different vectors that we use when we're testing the patient. And you want to make sure that in all situations, pre-testing to see if your patient can get a sub-Q ICD, that they pass in at least 2 out of those 3 vectors. So this is what it looks like. This patient passes in all 3 here. This is when they're laying flat. This is when the patient was standing, and you see they pass in the primary and the secondary, but they fail, or I'm sorry, in this one they also pass in the alternate. So, oops, that's not what I meant to do. Sorry, I didn't mean to go all the way to the end there. Okay, so these look pretty similar. So supine and then standing. And then we put them on a treadmill and see if things change. And you'll see that this lead down here changes. So they failed in that vector. So this is what it looked like before, and now this is what it looks like. So this is too much of a change that the device would see, and the device might mistake this rhythm for an abnormal rhythm because there's no leads in the heart. So they failed there, but they still passed in these 2. Continue exercise, still passing in these 2, top ones failing in the bottom. Same thing there. And that patient passed the screening, went on to get a sub-Q ICD placed. This was a hypertrophic cardiomyopathy patient and met criteria for primary prevention. So on that same day, we did testing for another hypertrophic cardiomyopathy patient who was presenting for a possible ICD for primary prevention. And so this is what the initial EKG looked like. And then at higher heart rates, you can see there's a complete change in your QRS morphology. So this patient actually fails all the way around. So this patient would not be a candidate. And you can even see during exercise here that this patient's switching between those two morphologies. So this patient cannot have a sub-Q ICD with the current technology because they could be shocked walking around because the device would think they were in an abnormal rhythm when they're not. And these are just the EKGs that we obtained during that time. You see the QRS morphology is completely different on these two EKGs. So this patient went on to get a transvenous ICD. And those changes sometimes can be missed by your preoperative testing and be seen later when they come back for their follow-up stress test, which is a problem. And because they can get shocked in the world and on your treadmill or bike. So in summary, it's really important to understand what type of device your patient has when they show up in your lab, know why they have their device, know how they're programmed, including what kind of therapy zones they have and whether you might want to turn some of those therapies off. Or if you leave them on, know when to terminate your test because your patient may be getting to the point where they might receive a therapy. And high-risk patients who may need reprogramming during their procedure or who may be at risk for events, I think it's useful to have someone in the room who can interrogate your device and reprogram your device real time. Thank you.
We have some time for questions. Please come to the microphone.
Kendra, I thought that was a really great talk. I really liked the examples. I thought they were really interesting.
Thanks.
I guess the question I had is for your patients that come in that are primarily managed outside your hospital, so like an adult patient who's managed in an outside hospital who has an ICD, do you interrogate those devices as well before you exercise?
Yes.
Yes, okay.
Always.
Thanks, Kendra. It's a great talk. I had a question because at Cincinnati Children's, in our exercise lab, there's still a little bit of confusion about the protocol that Boston Scientific's using when they're doing screening for the sub-Q ICDs. And it sort of, is there a target heart rate you're going for? Or you, like how hard do you want to push the patient? Because could they have a change in their QRS?
Yes.
Morphology beyond a heart rate that you might be looking at?
Yeah, so I think Boston Scientific's protocol, it's either 140 or 150 is the peak heart rate that they go for.
Okay.
I will push the patients to heart rates higher than that. These are kids, or teenagers who definitely have a risk of having changes in their QRS morphology when their heart rate's higher. So we are with them when they do that initial protocol and the initial screening, and that's why we will actually do them on the treadmill and push them further than what their protocol requires.
Okay. And do you typically just kind of marry that to a full cardiopulmonary exercise test, or do you keep them separate?
Yes.
Yes.
So sometimes, if the patient's inpatient and they will bring him maybe to the inpatient cardiac rehab room and just put him on the treadmill and do it there while they're on telemetry and use their protocol. The outpatients, we do usually marry it to a full CPET so that we can get that information at the same time, but it varies. It varies on when they last had their test and what information we're looking for.
And then one other question, you talked about keeping the device quote unquote open with the interrogator / programmer during the testing. Are you doing that default for all devices or just for the patients that you suspect you might make a change?
So I do it for everyone because it's sometimes the ones who I don't suspect who need the most things changed. And it's just easier, when you first interrogate a device, it takes all that time calculating through, you've missed your moment. So if we interrogate the device and then leave that interrogation open, anything we need to do during the test we can do, and if we don't do it, we just close that interrogation at the end of the test. So I do it for all patients with pacemakers and ICDs.
Okay, thank you.
I actually have two unrelated questions, so bear with me. Rate-responsive rate-responsive pacemakers. I feel there's somewhat of a bias by the electrophysiology team to have those tests performed on a treadmill because the theory is you have the muscle mass of your upper body exercising, but in some patients, especially the small ones, towards peak exercise, they're not moving their arms, they're just holding on. And with a cycle, my experience is that we have not had a problem. What's your bias and why?
Okay, so I am biased toward the treadmill in most situations, so I have to start my statement with that. And we don't let our patients hold on. So they're not allowed to hold on during their test. We do plenty of bike tests for a variety of reasons, but I prefer the cycle. I do think kids get better peak heart rates on our treadmill protocol over the cycle protocol. But I really base it on the patient and what they're able to do and what test I think I'm going to get the best effort from them on when I'm trying to figure out their rate responsiveness.
Okay, and this is a bit more controversial, and not necessarily with regards to those who have ICDs and pacemakers. Multiple PVCs, non-sustained VT, at what count would you then say enough's enough, and why?
Again, I have to express my personal bias, and my exercise physiologist will attest to the fact that I probably push patients a little longer through some ventricular rhythms than most people would. I really, again, base it on the patient. I think it's completely fine if you start seeing triplets to terminate that test. If you are uncomfortable with your patient and you think that they may have a ventricular arrhythmia, you can terminate the test. I tend to be doing tests to see if medications are working to treat ventricular arrhythmias, so I will often push through that. But also, we have our defibrillator in the room ready to go. We actually have the code book open to the weight of the patient and everything dialed in. Of course, we haven't had to use it yet, but I pay a lot of attention to safety when I'm doing those tests, and the exercise physiologists know. That means, make sure the defibrillator's on, make sure everything's ready to go. But I let the different people who do the test go on what's safe, what they feel like is safe for them. But for isolated PVCs, I don't usually terminate a test. Couplets, I don't terminate a test. I don't do it for triplets most of the time, but it's not wrong to do that.
Hi, David White from Children's Mercy.
Hi.
When you're looking at pacemaker function rate response, and you do on treadmill and we do as well, do you think it's better from a pacemaker standpoint to use a treadmill protocol that's very aggressive, like an aggressive ramping protocol where you really try to get their heart rate up really quickly and see if that pacemaker can keep up, or do you feel like it's better to do something a little bit more gradual with like an intermittent protocol with some steady state response?
Yeah, I think in that situation, most of the time it's better to do something more gradual. And the reason is I'm not looking to see what their heart rate does just at peak exercise. I want to see what happens with their activities of daily living. So I want to see, and most of the patients who complain about their rate responsiveness programming, it's not with peak exercise that they have the complaints. It tends to be more, I get out of my chair at school and suddenly my heart feels really funny and I feel dizzy. And so what I'm really trying to see is throughout the course of a variety of different activities, how is their rate responsiveness responding? So I actually prefer a gradual approach. Now, when I retest, sometimes I'm less gradual because there's a time limit there, especially if I do multiple reprogrammings. But the initial evaluation, I try to do more gradually. All right, thanks. And thanks to my great team. Thank you.